Good afternoon. Thank you all for joining us. I'm Joanne Starks with the Center on Knowledge Translation for Disability and Rehabilitation Research, or KTDRR, at CETL in Austin, Texas, and I'll be moderating today's webinar entitled Bringing in the Patient Client, the Grading of Recommendations, Assessment, Development, and Evaluation Grade Process. This is the third in a series of 4 webinars focusing on systematic reviews from evidence to recommendations. Before we begin, I'd like to go through some of the Adobe Connect logistics. You should be listening to this presentation through your computer speakers. If you need to turn up the volume, you can do so on your own computer in your audio settings. There is also a speaker icon in the bar at the top of the screen. It should be green, and you can also adjust the volume with the small arrow next to that speaker icon. If you have any questions or comments, please type them into the chat box on the left-hand side of the screen. Marcel or I will address these as they come up. We will be recording the session, but no one's name will be shown in the archive. CART captioning is available, and the link to the CART is in the Useful Links pod on the right-hand side of the screen, and it's also in the chat box. When you get to that link, it will open in a new window. There's also a pod labeled Useful Documents on the bottom right. You can download a copy of today's presentation as a PDF or in the text version. A listing of articles from the Grade Working Group website is also posted. Just select the file name and click on Download. Before we get going, are there any questions? Okay, let's get started. I want to thank my colleague Ann Williams for her logistical and technical support for today's session. This webinar series is offered through CETL Center on KTDRR, which is funded by the National Institute on Disability and Rehabilitation Research, or NIDR. KTDRR is sponsoring a community of practice on evidence for disability and rehabilitation research, and the series of webinars addresses systematic reviews with a special focus on what is considered evidence and why and how this evidence is qualified, synthesized, and turned into recommendations for clinicians and other practitioners. Today's presentation is about the grade approach with its emphasis on the values and preferences of patients or clients. A final reminder, please use the chat box if you do have any questions or comments. Also, at the end of today's session, I'll ask you to complete a brief evaluation form. It's now my pleasure to introduce again Marcel Dijkers, PhD, FACRM, Research Professor in the Department of Rehabilitation Medicine and Senior Investigator in the Brain Injury Research Center at the Icahn School of Medicine at Mount Sinai. Dr. Dijkers is Director of 2 NIDR-funded projects, the Disability and Rehabilitation Research Project on Classification and Measurement of Medical Rehabilitation Interventions, as well as the Mount Sinai Advanced Rehabilitation Research Training Project. He is also Senior Investigator for the New York TBI model system funded by NIDR. Marcel, please take it away.
Thank you, Joanne. Good afternoon, everybody. We are going to go deeper into our search for evidence, or at least methods of finding, qualifying, and synthesizing evidence. And today we're going to look at grades. The objectives are unchanged from previously. We want to have a closer look at what is done to turn research results into evidence that can be used to support practice. So nothing new here. This is session 3 out of 4, as Joanne mentioned, focusing on grade, and we pretty much will spend the entire up to an hour and a half looking at what grade is, how it differs from what we looked at before, and where it might fit in with efforts to determine evidence for disability and rehabilitation researchers. So if you have any questions, please type them in while I go on to today's topic. We started on June 4th with a look at what are systematic reviews, how do they in gross outline find and qualify and synthesize evidence, and had a look at one of the early crude hierarchies of evidence based largely on design. On June 18, we moved on and looked at the Oxford Center for Evidence-Based Medicine hierarchies, which not just covered interventions, but about all the types of questions that an evidence-based practice adherent might ask. And we looked at the AAN, the American Academy for Neurology hierarchies, which also cover a number of questions, and which much more than the Oxford approach strongly focuses on creating rather than just using a systematic review. Today there is great. The official title is the Grading of Recommendations, Assessment, Development and Evaluation, although between Joanne and me we discovered that the same abbreviation has been used with slightly different words or versions of these words, but we don't have to worry about that. GRADE has been in development since about 2000 by an international group of evidence-based practice, and in this case mostly evidence-based medicine specialists. They have published a number of papers, and the list mentioned there in the lower right-hand side of your screen provides you with the exact location of the papers. 3 introductory ones that were published in Allergy, 6 in the British Medical Journal that took the perspective of the users, and the Journal of Clinical Epidemiology is still in the process of publishing a series of no less than 20, of which today they have published 15 that really take the stance of teaching somebody who wants to develop guidelines according to the GRADE methodology, the various steps that need to be taken, and especially how to think about doing stuff one way or another, grading up evidence, grading down evidence, and what have you. The GRADE ideas have been widely copied. Some people say they take it over and do some modifications. Others presumably use the methods without modification, and then there's others that refer to them for specific components that they have built into their own methodology. For instance, AN, Oxford, NICE, which is in the British socialized health system, the branch that looks at evidence for various things, and even the World Health Organization is using a modified version of GRADE. And then there is many publications that use grade, but it's very hard to find them because the word grade, of course, is used in so many connections. So when I did a search about a month ago, if I just used the word grade, I got 113,000 hits. If I used the term grading of recommendations, assessment, development, evaluation, I got 84. The truth lies somewhere in the middle, but it's a lot closer to 84 than to over 100,000. Here are some of the ones I found when I combined the full term grading of recommendation, assessment, development, evaluation with the word rehabilitation and disability in Medline. These 6 papers came up in various areas of disability and rehabilitation science that had used the grade methodology. Some people affiliated with Cochrane, but some others too. So it's already becoming known. So what's so big about grade? Well, it is for creating systematic reviews and for creating guidelines. And they have clearly separate steps for each. Part 1, of course, always has to be do a systematic review or find an existing systematic review that covers the area you're interested in, or maybe find multiple and use the information in those to create the guideline. We will address later on how doable it is to use an existing systematic review. Number 2, grade is outcome focused. The evidence is reviewed and summarized separate for each outcome that an intervention or a diagnostic intervention may have. And only at that point in time there is an effort to combine evidence across the various outcomes to make a recommendation. Lastly, and that might be surprising for somebody who would assume that they need 20 articles to set forth what their method is, there is really very little in steps. This is what you need to do. And a lot of their effort in all these articles is to let you know what their mindset is and to give examples of how they go about with the focus on being transparent, making explicit as a guideline developer or sometimes even as a systematic reviewer, what are your values, what assumptions did you make, how did you judge, and write that all up, make that information available. So there is very little you must do this. There is a lot of, well, this is an option and that's an option, and choosing between grading up and grading down, you have to take these things into account and carefully study those, discuss them with others, and make a decision, and make sure you write down why you made the decision. And lastly, as of now, limitation that grade deals with treatment and diagnosis only, and as of now doesn't have anything to say about prognosis or screening or some of the other things that in Oxford or in AAN we saw questions and methods have been developed. So this and a number of these slides that follow are taken by the introductory article by Gordon Guyat as the primary author in the Journal of Clinical Epidemiology series, the first of 20, where they give an overview of the entire process, and basically papers through 2 through 20 are providing the detail, especially the detail as to how to think about, how to weigh stuff. But if you want a quick and dirty overview of the great method, just reading the first Guyat paper, you would do quite well. So one of the things they say there is that, well, GREAT is part of the issue of developing guidelines, but it's not all of it. And here on this slide and the next, all the steps that they distinguish are given, and only the ones that are in red are actually addressed by GREAT. The others must be done before or after you put GREAT into motion. So you first have to prioritize a problem. We ought to have a guideline on how to address primary health care for people with cognitive disability. 2, you establish a review team and or a guideline panel. Then 3, the panel defines the questions to be addressed. What specific questions do we have that we want answer for, so that we can tell people what to do, what not to do. Step 4, find and critically appraise systematic reviews as they exist, or prepare protocols for systematic reviews, and then do those systematic reviews. Do the searches, select the studies, collect the data, analyze the data. Step 5, assess or maybe reassess, because you might have done it in step 3, the relative importance of the outcomes. And you will see, we'll get to that in a minute, that GREAT is very big on the systematic reviewers and the guideline teams specifying what they think are the outcomes to be looked at, and looking at what is the relative importance of those. And for that they prefer to use the consumer's perspective, which may be nothing new to the people listening here, but in medicine the idea of pressing that the consumers are the ones who should specify the priorities, in some circles might have been very revolutionary. Step 6, prepare an evidence profile, including assessment of the quality of evidence for each outcome and a summary of the findings. And this is nothing more than creating what we traditionally have called an evidence table. The great people have split it into 2 tables that have different content and are for different audiences, but in the end it's what we call an evidence table. Step 7, if you want to develop guidelines, you have to go further. assess the overall quality of the evidence and decide on the direction and the strength of the recommendations you want to make. And we'll get into that later on. And everything that follows, grade has nothing to say about, at least as of now. They haven't waded into any of this. Step 8, draft the actual guideline. Step 9, consult with stakeholders or external peer reviewers. Get feedback on what you did, how you did it. Let them iron out some possible mistakes you made. Disseminate the review or the guideline. Update the review or the guideline when needed, every 2 years or every 4 years, or whenever you think there is new evidence that needs to be looked at. For clinical operations, adapt the guideline, if it's relevant to your particular operations. If there are multiple recommendations, prioritize them for implementation. And we're getting here, into the issue of KT and, moving from, a recommendation to actual implementation, which, is a much bigger, problem than, we may have thought just a few years ago. Implement and support the implementation of the guideline, evaluate the impact of the guideline and its implementation strategies, and update the systematic review and the guideline. And I only now see that apparently 11 and 16 are the same thing. I have to reread that and see exactly how Guyat phrased that, because as it is, it looks to be duplicative. Do we have questions about the gross outline of grade? If you have any, type them in. In the meantime, I'll move on to some of the details. This slide and the next one, together represents the core, of the grade methodology. You start off, with a question, and we just, for simplicity's sake, gonna just say that you have one question. What is the best way of doing X, Y, Z? Well, there may be 5 studies that address the particular interventions that have been used to do improve X, Y, Z. As I indicated before, grade distinguishes various outcomes, and those are in orange here. And it splits them between important outcomes and critical outcomes. And you can imagine that, if it comes up to a toss-up what to use, you would rather focus on the intervention that is best for the critical outcomes than the ones that are optimal for the important outcomes. Note here that the lines indicate between the gray boxes and the orange boxes that not every study contributes to the same outcomes. One may have looked at outcome 1 and outcome 2, but then, another study might just have looked at one particular outcome. The next step, in green, is to generate an estimate of the effect size for each outcome, and we need not go in detail here, but essentially you combine the findings of all the studies, that contributed to evidence with respect to one particular outcome and try to create an effect size. Next step, we go to the blue box, is rate the quality of the evidence for each outcome across studies. So now we tie together the effect size with the quality of the underlying evidence. And we already mentioned this before, that one of the nice things about GRADE is that it allows you to start off with an estimate of the quality of the evidence, but then grade it down as needed because of weaknesses, or grade it up, increase the rating because of specific circumstances. And we'll look in detail at those things. And then finally come up with a final rating of the evidence separately for each outcome. For outcome 1, for outcome 2, for outcome 3 here, is the evidence high, moderate, low, or very low? And we'll get into details there. So this completes more or less the systematic reviewing steps. And then if you want to go on to a guideline, it's on this slide here. Yes?
Sorry, we have a question. If you can clarify a little bit more the difference between important outcome and clinical outcome.
Okay. First of all,
it's critical outcome, right?
Critical outcome. Yeah. So, say, if you were studying, ways to improve independence level of people with mental retardation, so that they can live in the community instead of an institution. There were 7 studies done. Some looked at happiness, some looked at employment, some looked at ability to take care of one's own ADLs and IADLs. Well, if you want to talk about living in the community, probably ADLs and IADLs are critical outcomes, and happiness may be a less crucial one. So that's the difference between important outcomes and critical outcomes. You could even have unimportant outcomes, and I didn't bother to put these on the slide because do you really want to go through all this effort for an unimportant outcome? I don't think so. If you're dealing with medicine, you may have some outcomes. You are less symptomatic. That's an important outcome. But a critical outcome is you don't have side effects that give you new diseases or create disability that you never had before. So if particular medical intervention may result in serious adverse effect, those would be your critical outcomes. Okay, I'm going to go back to this slide. Here we've, the first step in going toward recommendations for clinical guidelines is now we're starting to look at evidence across all the outcomes. If the evidence for outcome 1 is high, and for outcome 2 it's somewhat high, and for outcome 3 and 4 it's low, and for outcome 5 it's very low, Well, what do you recommend for the intervention in question involved? Because the evidence for the different outcomes is not necessarily the same. And now you have to start taking into account the quality and the quantity of the evidence, but also the importance of the various outcomes. And you probably will try to find an happy medium, and we'll get to that in due time. And lastly, once you have made up the overall quality of the evidence rating, you go to the last box where you decide on the direction of your recommendation. Are you going to recommend in favor of or against a particular intervention? You grade the strength of the evidence, of your recommendation, the strength of your recommendation, which in grade is either strong or weak. And you do that taking into account the quality of the evidence, the balance of the desirable and undesirable outcomes, and the values and preferences of the patients, and if necessary, others are involved, the values and preferences of others. And lastly, and I think I haven't seen this anywhere than in grade, even if you have made a final decision, you still may want to reconsider that and make a somewhat different decision for environments where resources are not very much available. What's the use of recommending for a particular group of medical patients that they should be screened with an MRI when your recommendations might be used by minimally trained physicians somewhere in the middle of Africa who would have to travel 300 miles to the nearest MRI. It doesn't make sense. So in cases like that, grade is willing to say, okay, now let's look at what is doable in an environment with poor resources, and would we recommend something different? So this is the overview. Let's look at some of the details. Step 3, define the questions to be addressed. And we meet here an old friend, Pico, or Picot, or Picots. Ask the questions in terms of, for what population is what recommendation compared to what comparator, leading to which specific outcomes, at a specific time frame, immediately after treatment, 2 years after treatment, and if necessary in different settings, again the resource rich versus the resource poor. And you see here that outcomes, it's the positive outcomes, the negative outcomes, the costs of a particular intervention, and other burdens. It can be such things as, well, in order to get this treatment, you have to show up 3 days a week for 4 hours. That's a burden, if not on you, on the family members who have to bring you in. So outcomes like that are being considered. And all of these outcomes, at the beginning of the process should be rated on how important are they, and grade proposes to use a 1 to 9 scale, where 1 to 3 would be the unimportant outcomes, 4 to 6 the important ones, and 7 to 9 the critical ones. Now, ideally, the importance is based on patient ratings of the relative importance of various outcomes. Even better if you have systematic reviews of patient ratings, that would be the best. Of course, we don't often have those. We don't even often have studies, where people have been asked what's the most important outcomes for you. So second best is you put together an ad hoc group of patients and ask them to do ratings for you. And a third best is the panel members function as proxies for patients or for clients and go, well, in my experience, most patients don't think that XYZ is very important. They keep telling me the most important thing is not to have this particular symptom anymore. So grade allows you flexibility while indicating what would be optimal, but fully realizing that very often the optimal is not available. And quick pointing out that the outcomes and the importance of the outcomes is looked at 3 times. In step 3, which essentially is a preliminary classification. The panel says what are the possible outcomes and what's the importance of the outcomes. Because now we have to make sure that we do a literature search for all the outcomes, or at least all the outcomes that are important or critical. After they do the evidence searching and evidence analysis, they may come up with, whoa, in this literature, there's work that in some studies they found, not too often, but they found this particular negative outcome, an adverse effect that we never even thought about. Well, if the adverse effect is dying, that certainly is a critical outcome, and we better start taking into account an additional important outcome, or maybe critical outcome. So we have to look at what the evidence says about this new important outcome. And then in step 7, when it comes to making recommendations, again, the importance, if necessary, the importance as revised in step 5 is taking into account when making an actual recommendation. So the outcomes and their importance is important to grade, and they carefully bring it, put it on the table at various points. Step 4, find and critically appraise systematic reviews and or prepare protocols for systematic reviews and do these reviews. Do your searches, select the studies, collect the data, analyze them. Now, given the need to extract outcomes and classify the quality of the evidence based on information that's not likely to be in the available systematic reviews, a great panel that wants to follow the great methodology may need to redo the systematic reviews that are out there in the literature, especially the importance of looking at outcomes one by one and developing the quality of the evidence for outcomes one at a time, and then only combining them is not done very often. So you may not be able to just take a systematic review, however well it was done, off the shelf and used as input to recommendation development, but you may need to redo it. So that's a disadvantage. Now, here is how GRADE handles evidence that is available from the various studies. Essentially, the second column there is where they want to end up. They want to have the evidence for a particular outcome designated as high quality evidence, moderate, low, or very low. How do they get there? Well, they start out pretty much with calling everything that is based on RCTs as high quality evidence, and everything that's based on observational studies at low quality evidence. And then in column 3 say, well, in certain circumstances you can grade down or rate down the evidence for 5 reasons. Risk of bias, inconsistency, indirectness, imprecision, and publication bias. And we talked about, I think, all of them in previous sessions. We'll get into detail, especially detail how GRADE looks at these in a minute. On the other hand, GRADE, and in this it was unique, also said, well, but you can also grade up. You can assign a higher level of evidence if you have a large or a very large effect size, if you find a dose response, or if any confounding that is plausible would just increase effect size, would not wipe it out. Or if your systematic review of the evidence indicates that there is more or less zero effect size, there may be circumstances where any confounding you can think of would have pushed the effect size away from a positive one into 0. So let's start looking, we'll start looking at this in a minute. There is another slide I had prepared, but we didn't manage to clear copyright in time for put it up. So the reference is here to an article by Dr. Brozak in that series that was published in Allergy, where they talk slightly different about the 4 ranks and what evidence might fit in there, and how they what meaning they give to that information. So instead of having two starting levels, either high or low, RCT or observational study, Brozek allowed for four starting levels. The highest RCTs without serious limitation, or well-performed observational studies with very large effects. Then moderate would be randomized trials with serious limitations, or well-performed observational studies yielding large effects. 3, randomized trials with very serious limitations that would give you low evidence, or observational studies without special strengths and then very low RCTs that are very poorly done, or observational studies with serious limitations. And their interpretation of the meaning of these things was more along the line of, we will not likely come across, nobody in the years to come is likely to produce evidence that will change our minds. And they more or less abandoned that language because they said, well, we may have moderately strong evidence for something, but it's unlikely that anybody will ever produce very strong evidence, because there's just ethical issues associated with doing a randomized clinical trial that we just don't want to go in. So it's not likely that anybody ever will create stronger evidence. So we should move away from that interpretation. Also, it may be that instead of starting with 4 starting levels of evidence, they reduced it to 2 because Brozek more or less had moved the grading down and grading up from a separate step to one that more or less was connected to the initial grading. Okay, so these are the current ones, and with their interpretation: high, moderate, low, very low. We are very confident the true effect lies close to that of the estimate of the effect. We are moderately confident of the effect estimate. The true effect is likely to be close to the estimate of the effect, but there's a possibility that it's substantially different. Low is the true effect may be substantially different from the estimate, and lastly, for very low, it's very likely that the true effect is different. And this interpretation is not too far different from what AAN does in terms of the interpretation of its 4 levels, which they happen to call class 1, 2, 3, and 4. Okay, so when are we allowed to rate down? Well, I started by showing you that you start your evidence off either at the highest level if you have an RCT, or at the 3rd level if you have an observational study. Now, you can and maybe should rate down when what I have called you have small d issues. There was no allocation concealment, there was no blinding. There was substantial attrition of subjects, or maybe there wasn't that much attrition, but they didn't do intent to treat analysis. but only per protocol analysis. They seem to have reported outcomes selectively. The study had 4 outcomes, as we maybe could see in clinicaltrials.gov, but in this publication reported on 2 only. Why are they hiding the 2 others? And then there may be such things as stopping early for benefit. People who either following rules or not following rules, analyze the data on a regular basis as they come in, and at the moment that they find a statistical difference, cry out hallelujah and stop collecting data and rush into print. Even if you have predefined rules as to how often you will look at the data and how you will analyze to stop early, there's still problems with it, and Gray doesn't like it. Use of unvalidated outcome measures. If you have poor measures, you can grade down. And one of the examples they give is patient-reported outcomes, and we're back with our old problem that we had with the AAN guidelines, that very often in disability and rehabilitation, this is what we have, patient-reported outcomes, and if you automatically have to disqualify evidence because of it, we have a problem. And 2 weeks from today, we will look at this problem in detail. There may be carryover effects in a crossover RCT. There may be recruitment bias in cluster randomized trials. There are a number of issues that you say this study wasn't done as well as could have been, or wasn't analyzed as well as could have been. I am going to knock them down a peg. In observational studies, you may have some of the same issues. Poor measures, no blinding, but there may be other things like in case control studies, match not enough or match too much between cases and controls. In cohort studies, getting your exposed and unexposed cases not from exactly the same population. Flawed measurement of exposure and outcome. Recall bias in measurement of exposure, stuff like that. And then failure to adequately control for confounding. If you do not measure all relevant prognostic factors in an observational study, you cannot control for these things. So you have to measure them and then do an appropriate statistical analysis that controls for any differences in prognostic factors. And lastly, we have the issue again of incomplete follow-up. Rating down for imprecision has to do with the width of the confidence interval around the estimated effect size. And in typical grade mode, they don't tell you what is too wide a confidence interval. Yeah. They just give you guidance as to how to look at it. Yeah. And essentially say, well, it depends on what your outcome measure is. Yeah. If you are looking at a crucial side effect, whether an intervention may kill or not kill people, you better be very sure of the confidence interval. And be very sure whether the intervals between the treatment and the control or the comparator are different or not. But for other things, it doesn't matter that much. And if a treatment is cheap and has no or very minor side effects, we don't necessarily care that much. So look at confidence intervals, look at imprecision from that perspective. And in doing so, take into account the patient's values and preferences. Again, what are the important outcomes and which ones are not so important? What are the adverse effects? What are the burdens on the patient? What are the resources that are taken by the treatment and the comparator? And what's the sample size and the event rate in individual studies and in pooled studies? And I will not go into detail with respect to event rates, but essentially is a particular negative effect observed in 1 of 100 patients or 1 of 1,000 patients, and statistically, even with the same confidence interval, you may have some different decisions to make. As of now, in grades, the imprecision issues only have been discussed with respect to dichotomous outcomes. Cured, not cured. Being able to live independently, not being able to live independently. And not for either diagnostic studies or for treatment studies that use continuous outcome measures. And to date, the focus has been on relative risk, whether you calculate as a risk ratio, an hazard ratio, an odds ratio, and not other measures of how the treatment group compares to the comparator group. And they note that relative risk very often is fairly constant when you go from one subgroup to another, from one treatment to another. Wherever you work, it seems that males always do somewhat poorer than females. So relative risk stays the same, while absolute risk may be very much different. So they can see you. Sorry, I was looking at a slide for imprecision. I don't have one, so we have moved into inconsistency, where you may have narrow confidence interval of various studies each, but you have inconsistency from one study to the next. Study 1 finds that the treatment is better than the comparator. Study 2 has a large number of cases, but finds that intervention and comparator have about the same effect. The effect size is close to 1. And yeah, then there's a study 3 that finds that the comparator has better outcomes. Well, what do you do there? Traditionally, people might have said, well, I do a meta-analysis and out rolls a number, and if the number is positive, the experimental treatment is better. If it's negative, the other treatment is better, the comparator is better, and maybe, there is no significant difference and we don't say anything. Not surprisingly, Gray doesn't want to do it that easily, but starts looking at, well, can we resolve why there is an inconsistency? May it be because of these 3 studies or 5 studies or 12 studies differed in the population. They all studied people with spinal cord injury, but some had only tetraplegics, others had paraplegics and tetraplegics. One had an age cutoff at 50, others didn't have, etc. It may be the intervention. You may have a different dose of the same intervention. You may have allowed different co-interventions. You may have a different comparator against which an intervention is compared. Then the outcomes. You may have looked at different duration of follow-up. One study looked at after 6 months after treatment ended, what was the success rate, and another looked at 12 months. And then, of course, you always have study methods, low risk versus high risk, RCT, large versus small, you name it. So, Gray essentially says effect sizes due to population, intervention, and outcome should be expected, can be formally tested based on an a priori hypothesis, and may result in different recommendations for different subgroups, for different outcomes, for different interventions. However, if you cannot tease apart why different studies have different outcomes based on population, intervention, and outcome, you have to start looking at other factors that may be underneath inconsistency. And reviewers should start considering rating down evidence when the point estimates vary widely across studies, when maybe the point estimates are not that far apart, but they have very narrow confidence intervals, still showing that these studies have different outcomes for reasons we don't understand. Statistical tests for heterogeneity showing low p-value. If you calculate I-squared, the measure of heterogeneity, that doesn't take sample size into account if it's large. Whatever it is, this inconsistency reduces our confidence in the results in relation to making a particular decision. So here's some example. Well, here you have 4 studies. The red line indicates, say, the difference between the one study and its comparator in terms of relative risk. You see there is quite some spread in the relative risks, but all of them are on the good side of 1, and they overlap, their confidence intervals overlap somewhat. Here we pretty much would say, well, all these studies point in the same direction. As opposed to this study where there is 5 studies, 2 of them are negative, 3 of them are positive, and there is quite some non-overlap between studies. The confidence intervals don't overlap. What is going on here? Why are these studies so inconsistent? We should rate down the quality of the evidence as long as we don't know. Okay, third reason for rating down evidence is when it's indirect. And indirect means you borrow evidence from a neighbor. When the studies that provide evidence fail to match the clinical question exactly in terms of P or I or C or O, or even T and S, the evidence is not considered direct. And when there is not 100% match, the evidence is indirect, and the reviewer should consider rating down the evidence. If you are looking at treatments for people with traumatic brain injury, and the best you have available is from studies of people with stroke. Well, can you use this evidence? In some instances, you may say, there's 100% overlap on how this works in these 2 populations. There is no need to grade down. Others you'll say, there is some difference, and the evidence is not as strong as if the study had been done in TBI. I'm going to grade down 1 step. And in other studies you might even say I'm going to grade down 2 steps. Lastly, you should consider grading down for indirectness of evidence if 2 treatments are not compared directly, but only through a third one. You can only compare them through a third one. And those of you who have heard the term network meta-analysis know what I'm talking about. Well, let's go here. I think I covered the previous slide. Let me see. I can engage the arrow. There is the arrow. You have a study 1 that compared treatment A against placebo. Treatment A, 55%, placebo, success. Placebo, 35%, 55 divided by 35. Study 1, treatment A is 1.57 better than placebo. Then there's a study 2 that compared treatment B against placebo. And comes up with B is 1.75 times as good as placebo. Well, what can we say about treatment A versus treatment B? Nobody ever compared them directly, but they both have been compared with placebo. So indirectly, we have a comparison. 1.75 divided by 1.57 is 1.11. Treatment B can be said to be 1.11 times as good as treatment A. Again, grade says this is indirect evidence. You never know what happens in these indirect comparisons, and it's safer to grade down the evidence 1 step. Another rating down reason is publication bias. And I presume that most of you are familiar with that. If you have reasonable evidence that there is publication bias in the area that you are doing your systematic reviewing in, you again may rate down the quality of your evidence because quite possibly some important information is missing. And the simplest way of assessing whether you are dealing with selective publication bias is the funnel plot, which is not necessarily the best one, but it's the easiest one and the best one to and give me my arrow, please. There it is. Here you have a funnel which is shown in an XY space. Here's the effect size. The comparator is better. The treatment is better. Here is sample size. Small studies and high studies. Between them you can split this triangle in 4 sections, and you will know that there is studies in this section, there are studies in this section, there are studies in this section, and there's nothing here. Small studies that show the comparator to be surprise better than the treatment. Quite possibly these studies were suppressed, were never published. And Great is saying if they were published, they presumably would bring down the effect size from the minus 0.05 we find for the big studies, much more to close to 0, while at the moment, if we just look at the big, the small studies, we find almost without exception, high effect sizes. So, Great says, rate down the quality of the evidence. Here, are some more of the tests that can be used and what you can do against publication bias, which is not much because it's very hard to find studies that were never published in desk drawers. The good news is Great also allows you to rate up the evidence, and for 3 primary reasons: a large effect size, a dose response gradient, and all plausible confounders would increase our confidence in the estimated effect or create a positive effect out of where there is nil at the moment. Great warns you that all of these 3 will happen infrequently, and they will most likely happen in cases of observational studies, including otherwise very low quality evidence studies, before, after, time series studies, that type of evidence. So let's look at large effect sizes. Again, they have only developed this for dichotomous outcome studies, where you deal with relative risk, and they say that modeling suggests that if you have a relative risk of larger than 2, or on the other hand, a relative risk of smaller than 0.05, confounding is not likely to be an explanation. and you're okay to up the quality grading by one level. If the relative risk is even larger on the one hand or smaller on the other side of the scale, larger than 5 or smaller than 0.02, it's very unlikely that confounding is an explanation, and you may be justified in quality, rating up the quality by 2 levels. And they give you some additional information, and those of you who have studied Bradford Hill know that name, a guy who gave some guidance as to when are you safe to interpret correlation as evidence of causation. Some of his criteria come into play. If the onset of change is almost immediate, you probably have solid evidence that this intervention indeed brought about a change. If you know that without an intervention there would have been deterioration in your sample, or they would not have moved at all improved, you can have some more confidence that the treatment effect size can be trusted. And there may be additional indirect evidence that will allow us to have confidence. So, large effect sizes in disability rehabilitation. Mark Johnson keeps on trotting out the example. Well, look at people with spinal cord injury. Before you give them a wheelchair, they're confined to beds. They have no mobility. You give them a wheelchair, they can figure out how to take the brakes off and can start pushing themselves around. They're not good at it, they may have risk doing it, but their mobility from 1 second to the next shot up 500%. That's a large effect size. And we may have similar things, and being an SCI researcher, my examples tend to come from there. If in large numbers of cases, your ulcer development percentage goes down from old type cushions to new type cushions from 10% to 1%. Or if you have women with arthritic knees, whose mobility has been declining over the last 3 years, and you have evidence, and now you give them one of those injections into the knees that provide artificial lubrication, and all of a sudden grandma can run again. Those are the examples. Dose response, maybe cases where the change from before to after is that big, but you find a change, the more change, the more dose you give of particular treatment, to more change you observe. So let's look at this. This is hypothetical data from 5 countries. The United States with a very short length of stay in patient rehabilitation. To say England with a very long length of stay, and in between Canada, Australia, and Germany. And here, the light blue is the functional independence measure. if we can be confident that on admission, the functional independence measure in all these countries was more about the same, say 30, then seeing a discharge FIM score that parallels the the length of stay, gives us confidence that it's indeed the length of inpatient rehabilitation that makes the difference, as opposed to this study where the discharge FIM score is still oriented the same, but now length of stay is all over the place. And who's going to believe that more inpatient rehabilitation results in a higher improved functional status? Something else must be going on. Lastly, the confounders. Whenever we have an observational study, that means there is not randomization that took care to balance two groups on every possible prognostic factor. Or even if we have a smallish randomized clinical trial, we may still have the two groups being unbalanced. The method to take care of that is by statistical control, either ANGOVA or propensity score. So there's other methods of doing that. But as I said before, you can only do that for factors that were actually measured and actually measured well. And what you remains is residual confounding or residual biases. Now, in unusual circumstances, all these plausible confounders, everything underlying the remedial or residual biases pushes toward the explanation we would like to believe, not away from it. For instance, we measure patients, figure out who is the sickest, only treat the sickest people, do not treat the non-sick people, but after treatment is over, we measure everybody again. Some of you may know this as the regression discontinuity design. And here it's illustrated. We measure admission on the XYZ test. We measure discharge on the XYZ test. The high scores on the XYZ test do not get treatment. So before and after, they get about the same score, and here they are. You draw the regression line, and it pretty much is on the main diagonal. We would have assumed, if we had done nothing for the low-scoring people, they would have been here on the post-test. But what actually happens is we gave them a treatment, and on the post-test, we find them all here. And I apologize, I too late discovered that in transferring this slide from my computer to Joanne's computer, the regression line stopped being in the middle of these data points. But you get the idea, These patients, should be here, along the same regression line as the non-treated patients, but all of a sudden they all shoot up here. Well, there's only one explanation for it. It's the treatment. And nothing much you can come up with explains why these people all of a sudden 2 weeks later, are so much better, than the treatment. It's impossible to come up with, a reasonable explanation. So, this is one of the situations, where we, rate up because of, confounders, doing nothing or pushing closer to what we want to believe. So, we're back to step 5, and I see that I need to speed it up even more. I was trying to do. I already referred to this before. At this point, after you have determined the level of evidence for each one of the outcomes separately, you need to take another look at the relative importance of the outcomes. At least guideline developers need to do that, because as I indicated, new outcomes may have popped up. Step 6, prepare an evidence profile, including an assessment of the evidence for each outcome and a summary of the findings. And in grade, these are called evidence profiles and SOPHI, summaries of findings. And let's have a quick look at the first one. You would need to really look at those on your computer at your ease. But the first part of this evidence profile gives you the study, the limitations, the inconsistency, the indirectness, all the reasons for grading down, publication bias, because grading up is rather rare. Those are not in this table because it was probably in this actual study not encountered. Here's a summary of findings: placebo, antibiotics. This is a study of earache in kids, the relative risk and the absolute risk, and the quality of the evidence summarized in a visual. So that's one of the tables, and then the summary of findings pulls just certain elements out of this, and you can see here it's much simpler. Here is the outcomes, each line as in the previous table. Each line is the evidence for a particular outcome, placebo, antibiotics, relative risk, number of participants, quality of the studies, and some comments. So this is what grade tells you to prepare as the basis for actually starting to rating the quality of the evidence across outcomes and deciding on the direction and the strength of the recommendations. So you have now to determine what's the level of evidence, high, moderate, low, or very low, for the critical outcome, which is, or not just any critical outcome, but the particular critical outcome that has the lowest quality evidence. That's the one you want to focus on. You make a recommendation, as I said before, in favor of the treatment or against the treatment. You do that in 2 strength of recommendations as opposed to, say, AAN, where they have, well, essentially 3 and 1, I can do it, strong and weak, or as they also call them, discretionary and conditional. And in making your selection, you look at the quality of the evidence, the balance of the desirable versus the undesirable outcomes, the values and preferences of clients and patients, and the resource cost of the intervention. And that is great. And sorry, we are slightly over time. If you have questions, I'm not going anywhere. So please, type them in. My last 3 slides, are about the advantages and disadvantages of grades, compared to all the alternatives, or maybe more specifically, compared to some of the alternatives we have looked at before, AAN, Oxford, etc. Number 1, there's a clear separation between the quality of the evidence and the strength of the recommendations. And for some reason, an asterisk got in here, pay it no heed. There are explicit and comprehensive criteria for either downgrading or upgrading the quality of the evidence. There is explicit consideration for taking into account what outcomes are important to our patients, our clients, and focusing on those, giving those the most weight, when we have to come up with a bottom line. Number 4, there is an requirement for a systematic reviewer or guideline developer to be very upfront and explicit about the values and preferences that they have or that they assumed patients to have while making recommendations. And that makes the entire process to moving from what we might call raw evidence to recommendations very transparent. Anybody can read every step along the way, can look at the evidence, can look how the guideline developers argued, weighed evidence, what values they had and what they did with them. Great is explicit about making recommendations about for the most appropriate course of action, even when very little evidence is available. They're not hesitant to make a weak evidence even if there is very little, as opposed to, say, as I've complained about Cochrane before. Number 7 should be in the disadvantages, presumably. They, as of now, only talk about diagnostic and therapeutic courses of action. An advantage is that they give clear and pragmatic interpretations of what is strong and what is weak. And they try to strike a balance between simplicity and methodological comprehensiveness. And they don't have a very complex set of steps, algorithms, although if you dig into papers 2 to 20, some of the things that I've presented are more complex than I may have made them look, but just the same, it's a relatively simple system, which on the other hand tries to be comprehensive methodologically. On the limitation side, it doesn't deal with the questions of risk or prognosis or other things that I said AAN does. It doesn't do much, help you much with what Gordon Guyette has called motherhood questions. We tend to talk about motherhood and apple pie, what's wrong with them. And if you have questions about that, what's the evidence that rehabilitation is good? That's such a duh question that if you want to find evidence for it, grade may not necessarily be very helpful. You may consider as a complaint that it covers the red steps 3 through 7 only and not 1 through 16, although you can go elsewhere to get guidance for those things. As I said, they really have focused in doing the actual studies and developing the methodology on interventions and medical type interventions, and they haven't looked too hard, too far on diagnostic tests, public health, health systems, and probably disability and rehabilitation. Lastly, a grade, at least in its current incarnation, doesn't give you much guidance as to what to do with designs other than either RCTs or observational studies that have a control group. But if you have a strong pre-post study, if you have a strong single subject design, as of now there is no guidance, and what you may want to do is start them off as very weak evidence and see whether there is a good basis to upgrade them to weak, which may or may not be successful. Grade doesn't eliminate disagreements between panelists. It just makes them transparent, and you can write down what you were fighting about and what you eventually did to get rid of the fight, flipping a coin, bringing a third person, talk till you were blue in the face and convince the other person, what have you. In its search for simplicity, GREAT has what some may call a somewhat simplistic view of bias. Certainly they have no good word for methodological quality scales like we have seen the Pedro scale or the Jadat scale or one of the others. Their argument basically is you have to look at one characteristic of a study separately from another. You cannot average 2 strong points with 1 weak point and come up with 1 remaining strong point. It doesn't work that way. You have to look at all the individual items and based on each one separately decide whether you are going to grade down, not grade down, or even sometimes grade up. lastly, some people may have a problem, with the fact that, well, all of this is pretty much accepted based on the say-so of Dr. Brozak and Dr. Giat and 10 to 20 to 40 of their colleagues, but there's not necessarily is empirical evidence that if you develop guidelines according to their methodology, those guidelines are better, stronger than guidelines developed according to somebody else's methodology. And that is true, but the somebody else's also do not have empirical evidence. All of this is pretty much based on, well, we think so, our reasoning, our training in research methodology tells us, etc. And that brings us to the end of today. So again, if you have any questions, and thank you for hanging in there, going over time. Joanne is jumping in with, what my next slide is. Please fill out the evaluation form, and if you think it's shameful that I went over my time, please don't hesitate to put it in there, and we'll find out a way for me to stop talking so much and going over the time limits that I had promised I would take into account. In 2 weeks we'll have the last session, so if there is something that you by all means would like us to address, either in that session or in a later one, let us know. Provide feedback on today's session by completing the survey, and raise your finger when Joanne will start asking you to actually become a participant in the community of practice dealing with issues of evidence.
Okay, well, thank you very much, Marcel. I wanted to note that we have quite a few people that did hang in with us after the time came up, so that was great. We had a few that must have had to leave because they already had set aside the time. But I just want to give a big thank you to Dr. Marcel Dijkers and to everyone who participated today. We do have a brief evaluation form, and I've put the link to that there in the chat box, and we'll also follow up with an email. A reminder that we do have the archives posted for the first 2 webinars if you would like to review them, and today's archive should be available in a week or so. We appreciate the support of NIDR to carry out these webinars and our other KTDRR activities. And as Marcel said, the final webinar in this series will be on July 16th, so we look forward to seeing you all in a couple of weeks. Thanks very much and good afternoon.